All right, I guess we're going to go ahead and get started this morning. Good morning, everybody. Thanks for being here. Welcome to Friday Morning Medical Conference, sponsored by Western Montana Area Health Education Center. My name is Darren Bell. I'm on faculty with the Family Medicine Residency at Western Montana. And this morning, it's my pleasure to welcome Dr. Nathan Richards here, who will be speaking to us about robotic surgery. Dr. Richards is a general surgeon in Salt Lake City. He primarily operates out of LDS Hospital and Intermountain Medical Center and specializes in minimally invasive surgery of the foregut and abdominal wall using advanced laparoscopy and robotics. Since he joined Intermountain Healthcare in 2013, Dr. Richards has focused on advancing robotic surgery in appropriate and responsible manners. He performed the first robotic-assisted Heller myotomy in the state of Utah and was also the first surgeon in Utah to perform a robotic-assisted Whipple procedure in December 2014. In addition, he also pioneered robotic central pancreatectomy, robotic transduodenal sphincteroplasty, and spleen-sparing robotic distal pancreatectomy. He also has extensive experience in robotic incisional hernia repair and colectomy. Dr. Richards is the general surgery representative for the Intermountain Healthcare Robotics Development Committee and focuses on implementing safe, data-centered, and cost-effective utilization of robotic surgery within general surgery. And just as a note before he actually comes up, we will take questions at the end using the remote mic. So if you do have questions, we'll be handing that around. So without further ado, welcome Dr. Nathan Richards.
Thanks so much. Appreciate it. I was impressed with the way you rattled those procedures off. I can't do that fast. Pancreatic. Yeah, it was impressive. Well done. Well done. Thanks again for the opportunity to come. It's a privilege. We were just talking earlier. I'm excited for the sun to come up so I can see how beautiful Missoula is. I've heard great things, and I'm happy to be here. Just a little bit more about me. I grew up in Salt Lake City, Utah. I did my training medical school at the University of Utah, and then I subsequently did residency in Philadelphia and a fellowship in DC. I've been practicing for just over 3 years, just under 4 years, somewhere between there. We'll say 3.5 years. I currently do a lot of robotic surgery. I've done probably 100+ cases in that time. I'm not an all-in robotic surgeon. Most of what I do is still laparoscopic. But I do see that there certainly are some potential advantages and disadvantages. And today, in talking about robotics, my hope is that you'll see a fairly objective kind of analysis of where we are and where we're going. I'm going to do it in the setting of general surgery because that's what I do. Certainly, robotics has entrenched itself very well in the urology sphere as well as in gynecology, and it's pretty universally accepted in those specialties, those disciplines. But in general surgery, it's still relatively new. So I always have to start off with my favorite comic, which is awesome. So this is Calvin, and he's, of course, assigned a report on the brain. And the strip before this shows him playing with his buddy Hobbs, procrastinating per usual, eating his chocolate-covered sugar bombs. And here he is standing up to give a 5-minute report on the brain. And, of course, it's difficult to explain complexities of the brain in just 5 minutes, but to begin, the brain is part of the nervous system. Checks his watch and says, I'll give you 5 minutes so you can all finish writing that down. And so here we're going to talk about robot surgery, and go ahead and take some notes, and I'll wait. In looking at robotic surgery, I'd like to talk a little bit about the future. And so we'll use a little bit of divination. I did just see Fantastic Beasts and How to Find Them with my kids last weekend. It's a great movie. So I definitely plug here for that. But it has nothing to do with robots or divination, frankly. But I think we'll look a little bit, if we can, and do a deep dive as to where we're going with robots and kind of what's going to be relevant to surgeons as well as to the rest of us who are going to interact with this technology. And so I'd like to give a little kind of overview and see where we are. Initially, I was going to put up a bunch of great bloody videos and say, hey, this is the portal vein, and this is the robot, and I'm dissecting it, and blah, blah, blah. But I decided not to do that because you've all seen it before. Anyway, how did we get where we are? Where are we now, and where are we going? And I think more importantly, we'll talk about why. Why are we doing this? Why is robotics a disruptive technology? Why is that making a difference, and should we be doing it, I guess, is what we'll be talking about a little bit as well. A little bit more about me. I did, in college, I majored in economics. I'm a little bit of a geek, and I also love history. One of my favorite philosophers, who's credited for talking about, history, specifically his famous quote is, those that don't learn from the past are doomed to repeat it. His other one, you hear about fanaticism from George Santana. It consists of redoubling your effort when you have forgotten your aim, which I think there are certainly those in the robotics community that could probably fit that description, where we're using a several $1 million piece of equipment to do a procedure that we can make longer and more expensive with really no benefit. So I think it's important for us to remember kind of where we are. Robotic technology, exists to help us provide minimally invasive surgery options to patients in ways that either equal or improve the standard of care. And if we can keep that as our why, then I think that the rest of this hopefully will begin to make sense. So given the pace of technology, I propose we leave math to machines and go play outside, which again, once the sun rays, it comes up, I think hopefully that's what I'll be doing. Back to my economics, a little bit of economics background. I wanted to talk a little bit about diffusion of innovation, and this hopefully will explain a little bit about how we got where we are. How did we get here? Everett Rogers in 1962 proposed, using a bell curve to describe innovation and how it kind of diffuses across, the accepted world, basically. And he kind of breaks down the bell curve into different categories, different subgroups. And the first of which, those that start this innovation are the innovators, the technologists, those that see a need, recognize that, aha, there's something that needs to be done here. In a surgical standpoint, we're doing, open cholecystectomy, and we're cutting through the rectus muscles, and patients are miserable. There's got to be something different. And so those innovators decided, what if we make a few small holes and put in a camera, and we do this, laparoscopically. So that's a classic example. And, initially 2.5% of the surgeons were doing it and said, yeah, this is really great. Saw the vision. Talked to the next subgroup and kind of encouraged the visionaries, the early adopters. And again, it's still up to about 16% of docs, catch on. And then you see, once you get to that kind of 16% window, we'll talk about this in a second, you've moved pretty quickly into adaptation. The early majority of surgeons then, or people rather, and this is again any kind of innovation, are the pragmatists. They recognize that there's benefit to that innovation that's disrupting the market. They're recognizing that, oh yeah, this is something that we should do, and they adopt it early. Then they talk to their peers that are happy doing what they're doing and don't really want to change. I'm relatively conservative. Is this really going to make a difference? Or am I just wasting my time? I always, when talking about this group, I think of the LCD, the laser disc player, right? So that one that was around in the mid-90s that was like huge, that lasted for a few years and then died because nobody really wanted to put in a huge laser disc and then have to flip it over. That was silly technology. But, those early adopters regretted that one a little bit. The conservatives won on the laser disc. And then, of course, there's my favorite term that he came up with, which is the laggards, and you have to say that almost with a Scottish brogue, the laggards. But anyway, so the skeptics, the laggards, and I still think, and there are those that will tail off in perpetuity. And most of the time, if this innovation is disruptive enough, the laggards will be left behind. And I think, that potentially is a fear of any innovation that comes through. So what does this have to do with us? Before we get to the surgical adaptation, again, we talked about that 16% mark, and Everett Rogers proposes that at 16%, that's when the technology and the drive is sufficient to push it into the majority. Two famous economists, Malcolm Gladwell, who most of us have read. If not, you should. It's phenomenal. Writes a book called The Tipping Point. And then Jeffrey Moore also describes this chasm, and you can see, the bell curve from Everett Rogers here. The chasm he defines as that 16%. And his book basically directs us how to market and sell disruptive products to mainstream customers, how to cross that chasm. And we'll talk a little bit about that. So what is the tipping point or chasm, and how does it relate to robotic surgery? And again, you can see I've kind of created that to understand what it might be for surgeons, I'm going to make 4 fundamental assumptions. And again, I'm a surgeon. I'm talking about surgeons, so take it for what it's worth. But I think, and I'll propose, that surgeons, the first assumption we need to make is that we want what is best for patients. I think we all do. That's what we wrote on our essays when we applied for medical school. And I still think it rings true, that we want what's best for patients. Of course, those of you that aren't surgeons in the rooms will certainly agree with number 2, which means that surgeons want what's best for surgeons, right? We tend to be relatively selfish. I'm happy to own that stereotype a little bit, try not to be, but nonetheless, I think most of the time we want what's best for us. You know, I don't want my back to hurt after a 7-hour, you know, laparoscopic surgery in a super morbidly obese patient. It's not necessarily sustaining. And so if I can find out a way to do that ergonomically, I'm going to do that because I want what's best for me. Gratefully, we generally migrate to doing what's best for both. You know, so we can certainly maintain quality patient care, but that we can also maintain things that will actually help us and benefit us as well. And then also we'll note that surgeons, and I think probably most of us, will justify our views via either condoning or criticizing the change. And that's where we are, you know, we've fallen here. And I think as we look at these general assumptions, we'll see how that, you know, specifically robotic surgery is adopted. So this is a busy slide, but you can see that what I'm going to define as the tipping point is where that 60% of market share is achieved and adaptation of the innovation takes off. And each category of adopters, again, the innovators, you know, influence the early adopters, which influence the early majority, which influence the late majority, which eventually lead to the laggards adopting technology. I think from our standpoint as surgeons, the early market, that first 16%, you know, we want what others can't have or don't know about. We want to be on the leading edge of, you know, what's the next great thing. And whether it's from a marketing standpoint, which, you know, admittedly, certainly there's going to be an element of that. You know, it's easy to separate yourself as a robotic surgeon if nobody else around is doing it. You know, I think that certainly is a force. Or you want to be able to do a minimally invasive hysterectomy, whereas it used to just be open, and you recognize that there are benefits there. And we'll talk a little bit about that. And then the critics and adopters, their mode is going to be, you know what, I think I'm probably going to join those 2,000 or so other surgeons that are already adopted this technology and they're getting good results. I want to be what they have. And so that's how that's going to progress. The classic example, I referenced it a little bit earlier, but this slide is taken from a couple of articles, one in the Lancet in 29 where Barkin et al. Kind of maps out the adaptation of laparoscopy and cholecystectomy as well as bariatric surgery. And you can see that in his case, the innovation really disrupted the market. So that within, you know, 2 years, we went from 0% laparoscopic cholecystectomy to, you know, 80 plus, or almost 80%. And it's maintained that going on, you know, in perpetuity. And the reason for that was because it was better, right? A laparoscopic cholecystectomy, no brainer. It's really interesting to go back and look at how that was and talk to those innovators, those, you know, early market technologists and the people that got there, and talk about how the resistance came from the medical establishment and the patients clamored for it. You know, they said, yeah, it's no brainer. If you can not cut my rectus muscle, I want that. And they self-selected to go find the doctors that were doing laparoscopic cholecystectomy, to the point where, you know, the community medicine, the community surgeons drove that innovation, and it was ultimately adopted by everybody. So now almost everybody does laparoscopic cholecystectomy. Similarly, bariatric surgery, you know, has a very similar. I'm sorry, this is Nissen fundoplication, and then bariatric surgery, you can see, is also starting to take off because, again, patients want to not have pain. It's just a pretty simple thing, and you can see that the innovation has allowed that to happen. Where are we now? I think looking at kind of the meat of my talk, and this is, again, more of an overview slide, but I'm looking at current or emerging uses of the robot in general surgery. Again, I'm not going to cover gyne or urology other than just a few references. I think hysterectomy provides a pretty good model, and we'll talk about that a little bit. But as far as general surgery goes, I think there's a great need and a great push, and some of it is marketing from Intuitive, who has a monopoly on the robot, the Da Vinci robot, to get surgeons to look at a hernia. But I also think that there's benefit there, and we'll talk about that. So, you know, abdominal wall hernia, you know, hindgut, you know, colectomy, LAR rectopexy, foregut. Again, Heller myotomy, which is a procedure done for achalasia, where we incise the lower esophageal sphincter to allow patients that can't eat and can't pass food through the esophagus into the stomach so that the food can actually get there. It's a fun surgery to do, frankly. And the patients, honestly, there's nothing I like better than doing that surgery and then walking into the patient's room the morning after and saying, here, have a drink of water, and then watching their eyes just go, it's fantastic. So again, surgeons like doing what's best for surgeons because that's super satisfying. But anyway, hiatal hernia, fundoplication. I think there's a role for this in complex, oncologic surgery as well. And there probably aren't more complex surgeries that can be done than a pancreatic duodenectomy, than a Whipple procedure. I think the robot really shines there. Certainly, it's a task. The first Whipple I did in 2014 took 14 hours, which is ridiculous. Admittedly, the last one I did took 6. And so, certainly there's a learning curve, and then there's roles for that. But I think we'll see, and I'll talk a little bit about some of those advantages. And then there's, all sorts of things that we're probably not going to cover today for time and whatnot. And those are, the adrenalectomies, the splenectomies, the gallbladders, cholecystectomy, et cetera. Looking at kind of current, I'm going to just pick a few surgeries within the general surgery realm. Rectal resections for low rectal cancers, colon resections, sigmoids, right colons are all grouped into that group. Inguinal hernias and ventral hernias. And this is kind of a distribution of where, what type of surgery is used, what technique is used for each of those today. So this is a picture from 2010 to 2015, looking at data from what's called the Premier database, which is about a third of the hospitals in the country subscribe to. Just do a huge data dump, and then that database is trollable, it's mineable. And so basically, in looking at what's happening in a third of the hospitals today, we can get a pretty good picture as to how this is breaking down. And you can see that even today, in 2016, the vast majority of low rectal resections are done open. Colon resections, almost 50% are done open. Inguinal hernias are still done open, and ventral hernias are done open. And you can argue, I think, very appropriately, we're not going to do it today, as to why that's the case. Certainly there are some surgeons that will go down, with the laggards. That's my opinion, of course, that's the way to go. And I think that you can make fairly compelling arguments that that's the case. But this is where we are now, and I think there certainly is room for that innovation and disruptive technology to kind of take over here. This is a slide that kind of predicts growth trends in minimally invasive surgery, both laparoscopy and robotics. We're kind of trying to predict the trends in minimally invasive surgery across these different procedures. And again, you'll see here I did throw on hysterectomy here. But what you can see, if you put my market share chasm, this is kind of rectal resections. You've got, all of these others, and you can see that laparoscopic technique has kind of reached its plateau, for lack of a better word, and it's either decreasing in market share or it's just kind of staying stable. Whereas a lot of the growth curve you'll see is the doctors adopting the robotic technology. And we'll talk a little bit about why that is. You can see most profoundly that you got a 347% increase in patients doing hernia, and they're predicting that within this year we're going to cross that 16% market share chasm to get minimally invasive hernia more adopted by the mainstream. So if you kind of apply that to what we've talked about, this is one of the reasons why that's happening. If you look at, this is a slide for hysterectomy, where we look at back in 2000, the red here is open hysterectomy for cancer, and then this is robotic hysterectomy, and then the laparoscopic technique, and then the transvaginal technique are these other two lines. And you can clearly see that once they hit the 16% of gynecologists started to use a minimally invasive technique, they went from open, which they were doing well, and that has dropped pretty remarkably down to 2013, where it's less than 20% utilization for an open hysterectomy. It doesn't happen as much anymore because they get equal results. The patients are happier, they have less pain, et cetera, et cetera. These are classic examples in 2003 prostates. If you look at a breakdown again, the tan here is open, the purple is robotic, and then lap is a little bit darker purple. You can see in 2003, almost all of the prostatectomies in the country were done open. when you look at 2015, 85% of the prostates were done via the robot. The laparoscopic share hasn't changed at all. So what we see is that the robot has allowed surgeons that would have otherwise done them open to do them in a minimally invasive fashion. Same trend for hysterectomy for cancer and benign. You can see that, again, it was all done open. Here we are in 2015, and almost 50% are done in a minimally invasive fashion. Note that the laparoscopic approach hasn't really changed much. The surgeons that are doing it lap are still doing it lap. The big difference is those that were doing it open are now doing things in a minimally invasive fashion. And then again, benign hysterectomy follows the same pattern. The open diminishes, and then you've got robot, lap, and vaginal approaches. So that's where we are. And then looking at those same four procedures we talked right through lobectomy on, just to kind of show you, but you see that in 2009 when they started to kind of look at this data, you know, the open component of kind of the distribution of how it's done has really shrunk pretty dramatically. You can see in each of those, you know, the Da Vinci or the robotic approach has been chipping into the open approach technique. And so surgeons that are, you know, I'm kind of the same point, I realize that, but the surgeons that are doing it open with big incisions, keeping patients in the hospital with increased risks of infection, increased pain, all of the things that we see with open surgery traditionally, that is going down and patients are receiving that care. And we're in that market adaptation phase of the diffusion curve. So with that in mind, looking at specifically hernia, and what we're going to do is just go through a few of those topics within general surgery and kind of show you the data a little bit. And this may be hopefully not too intense of kind of an expose, but what I'd like to do is just look at kind of where we are, why use the robot in these different techniques, and so you guys can see, and hopefully we can all participate in saying, okay, this is why the robot's used. It's not just marketing, it's not just this or that, and why maybe should we not use it. So looking at hernia, you know, it's a major area of focus across minimally invasive surgery. The problems are we don't yet have any peer-reviewed literature. It's relatively new. We're creating cohort studies. We're looking prospectively and retrospectively to try to analyze, is this beneficial? To answer that initial question, right, does robotics allow us to be equal or better than the standard of care? And we don't know from a peer-reviewed standpoint yet. And so how do we find out? And how do we get that data? And I think it will come, but we don't want to be, most of us don't want to be in the laggards or the conservatives. For the most part, I'm okay being conservative, frankly, but I want to be doing what's right for the patient. So most of us want to see, all right, well, is this going to be great? How do we find out? And in the absence of peer-reviewed literature, what can we do? So it's really fascinating to watch, even on Facebook, and I put that down here because it hurts to write that, frankly. But between political and recipes, there's actually a nice use for Facebook. There's two groups on Facebook, one of which is called the International Hernia Collaboration, the other is the Robotic Surgery Collaboration. And what basically they each have just over 2,000 members. It's a closed group. You have to be verified as a surgeon or a medical professional, and it's all by referral. And basically on these websites, it's an open share community. It's an open source community where docs will post, say, hey, I just did this robotic hernia repair, and this is my technique, this is what I use, and they'll post, a sped up video. And, usually we'll speed it up to about 3 times so we don't all have to watch everything separate, together. But, and then they say, here we are, and then the comment stream will follow. And certainly there are those on there that will use it for self-aggrandizement and gratification, but what we find pretty routinely is that there are comments that you can go back and look at. And so if I have a patient who has a very similar hernia and I see that this guy did this approach and it's working fairly well, and I can see the comments of, hey, maybe you should try this, or I did this and this works better, it gives me that community and it gives me techniques. And I've done that. It's really been neat to see in my own practice as I've seen patients with hernias and kind of use those techniques, and that what's available to me on Facebook, say that again, somewhat ashamed, to really increase and strengthen my practice. The interesting thing is, and we'll talk about it too, is that the leaders that established this one particularly, the Robotic Surgery Collaboration, are the leaders that are, in that less than 60% curve. They're the guys that are now actually, the guys and girls that are now actually publishing the data and getting the numbers that are necessary to establish cohorts. And we'll quote one of their recent studies on hernias here in just a second. But the robot is used for inguinal hernia, and I've got a lot of letters that are just sitting up there staring at us, and what does that mean? So our TAP is a robotic trans-abdominal pre-peritoneal approach for a hernia. Basically what that means is I'm going to take the abdominal wall and I'm going to separate the rectus sheath, and basically I'm going to go pre-peritoneal, so I drop the posterior sheath or the posterior peritoneum below the umbilicus, and I just make it a flap and I drop it down, so I'm looking just below the rectus muscle, and I'm going to go and identify the hernia. I'm going to pull everything out, and I'm going to repair that hole, and then I'm going to put the flap back out. And so I don't have anything, most of my repairs outside of the abdomen per se, but in the belly wall. Does that make sense? So that's what the TAP is. So IPOM stands for intraperitoneal onlay mesh. So many of us will do, especially for ventral and incisional hernias, where we'll go into the belly and I'm looking at the guts, and then I look up at the ceiling, at the abdominal wall, and I'll fix the hernia. I'll sew it closed, and we'll decrease the tension that's on there, and then I'll take a piece of mesh and I'll put it up against the ceiling, up against the anterior abdominal wall in the peritoneum. And those meshes that we use are coated for anti-adhesions and all of that stuff. But I sew that mesh around and leave it in place so it stays in the peritoneum. So those are the difference between those two techniques. One of which, the mesh will sit in the muscle layer, the other will sit in the peritoneum. And otherwise, that's basically what all that means too. Component separations is that I can go in and cut the muscle layers to relieve tension and separate the components of the muscle in the abdominal wall so that we can decrease the tension and get the hernia to heal without recurrence. So that's what we're currently using. Where are we? Where are we going? Again, there's minimal peer-reviewed literature. We know that it's equivalent. We know that it's safe based on what's published, but we don't know if it's better. Pros to hernia. We can do primary fascial closure, which again, without getting super technical, recognizing my audience, I think it's important to either close the hole or not. In laparoscopy, so I'll have to even take a step back further. In open hernia repair, you cut down through the skin, you identify, aha, there's a hole, and then the idea is to close the hole. And usually we'll use things to reinforce that with, to get it to stay closed like mesh. And that's the whole idea of using that. In laparoscopy, you can't close the hole. I'm sewing upside down with chopsticks, and I can't get that angle to close the hole with really any reproducibility. I can't get the tension I need to tie knots like this. It just doesn't work. And so then, do I stick a needle in through the belly wall and try to cinch it that way, and I end up, tying relatively loose knots? It just doesn't work from a technical standpoint very well. And so most of us won't close the fascia primarily doing a laparoscopic hernia repair. Instead, we use the mesh to bridge that defect. Okay, so that's the difference. Looking at primary fascial closure, and the next slide we'll talk about that a little bit more. In a laparoscopic approach, I take a mesh, and again, because I can't sew, I use a tacking device. That basically it's an absorbable screw that kind of screws into the posterior fascia, the posterior peritoneum, in variable lengths. And again, you can imagine that in an obese patient, there's going to be a big difference between how far that screw sits. Is it going to make it to the fascia? Is it not? Is it going to get stuck in pre-peritoneal fat and not be adequate? And that's, I think, where we can, the big worry of those of us that do hernia surgery is the hernia going to come back? What is our recurrence rate? And we see that there's a significant degree of variability, particularly in obese patients. And one of those is because, does the mesh purchase well enough? Does it sit in before it moves away because those tacks aren't adequate? And so, all of these questions are driving this innovation. How do we make it better? We recognize that, half of hernias in America are still done open, and the reason is because we haven't perfected the technique yet. And I think we'll talk about robot a little bit. The hernia is a great training case. Those of us that, you certainly want to maintain your skills in hernia repair. We sew, we have fine dissection, and gratefully it's relatively low risk. There aren't too many structures that you can get into. It's certainly nice to have sewn, in a relatively fine technique, sewn a piece of mesh to the anterior abdominal wall before I have to sew, a hole in the portal vein with the robot, which makes it, other than the sphincter tightening, is pretty intense. Robotic hernia cons, of course, it's the cost. And here, we'll talk about the bazooka effect, meaning, I'm taking a bazooka to a knife fight. Do I really need to do this? For 100 years, we've done open hernia repair through a small incision, 3 or 4 centimeters long. Do I really need to bring a $2 million piece of equipment to make that better? And I think that's a very fair argument. It's overutilization of resources. And certainly in today's environment with shared accountability, providing that care and asking those questions is going to be something we have to do. And so, I think that there's a downside to that. Certainly we'll talk about cost a little bit. And again, we don't have data. We don't know what the recurrence rate is going to be. Even on Facebook, I pretty much guarantee that nobody's talking about their recurrences, right? Hey, I did this hernia. No, guess what happened? That just stays off Facebook, just the same reason we all look beautiful on Instagram. Here's a few studies, and they're fairly busy, but I'm not going to go through too much. But what we're looking at here is that fascial closure, and this is probably the best study I could find. It's a systematic review from PubMed, Cochrane, and Embase. And basically what we looked at is what is the recurrence rate of bridging versus closing that defect. Bridging the defect, with no closure, you have a recurrence rate in these comparative studies of up to 16%, 5 to 16%, whereas closing that defect appears to give us, a better chance of no recurrence, which makes sense. I mean, it's intuitive. It's common sense. If you close it, it's not likely to open, as opposed to if you leave it open, it's probably going to stay open. Again, seroma formation, which is another thing that as surgeons we worry about. Post-operatively, patients have a big bulge, there's fluid there, it can get infected, etc. Again, closing the defect, may have a slight benefit to seroma formation versus not closing it. And again, it's low-quality data. We don't have any randomized controlled trials to say that that's better. But what the robot allows us to do is to essentially perform an open surgery in a minimally invasive fashion. I can close the defect like I'd like to, and I can use mesh and appropriately place it under vision, which I can't do open. So it gives me the best of both worlds. This is probably the best and biggest study that's out there looking at robotic-assisted ventral hernia repair. And again, the 5 surgeons that are here, all of these doctors work at 4 institutions, and those are the leaders on the robotic surgery Facebook group. It's interestingly enough. The 368 hernias, you can see the breakdown. Surprisingly, almost 50% of them, I should say not surprisingly, are obese. But 20% of the patients have a BMI over 40, which traditionally in an open and even a laparoscopic approach, if I see a patient in my office, if they're not incarcerated, they're going to lose weight before I do that, because otherwise the recurrence rate's, ridiculously high, upwards of 50%. And so most of the time I wouldn't touch a hernia in a patient whose BMI is over 40. And these doctors within, using the robotic technique have, basically taken that on and said, well, is there a difference? And I'm curious to see what their outcome is. We don't have long-term outcome on that, so that'll be a question. But they found that from a robotic standpoint, only certainly less than 1% of them had to convert to an open surgery. Usually they'll do that for bleeding or a bowel injury is my guess. And total complications, the rate is 8.4, which is really remarkable at 30 days when you think of all the comorbidities that will come, with patients that, almost 60% of them have a BMI greater than 30. So a 30-day complication rate of 8.4% is pretty impressive. And the length of stay for the robotic hernia is 1 day on average, which again, you take a BMI of 40 patient with a big incision, they're in the hospital for 4, 5, 6 days typically. So you can see here where the innovation is starting to show up. I'm probably going to skip this slide. It's way too busy. Moving away from hernia onto colorectal surgery. So why would I want to use the robot or to do colorectal surgery? Again, we'll talk about everything in the colon, including the rectum. Basically, and what we've seen from the slide I showed you earlier is that this allows us to do minimally invasive surgery on patients that otherwise may not get that. Now, certainly there are surgeons out there that can do a wonderfully competent and efficient laparoscopic low anterior resection for an 8-centimeter low rectal cancer or a 5-centimeter low rectal cancer. I have a partner who's super slick and he does a great job, gets a great TME and a great nodal harvest laparoscopically, and is not necessarily excited about using the robot. And frankly, I agree. I wouldn't either if I were him. But there's most of us out there probably can't do that surgery very well, or we take shortcuts so that we can do it laparoscopically. And we'll talk a little bit about a study that shows that, in fact, it's this study here, the ROLAR study, which compared robot and laparoscopic surgery to open, and found pretty compellingly that there's not superiority to either minimally invasive technique in the vast majority of patients because of the fact that it's not necessarily working well. So, there's some arguments to be made. I think the robot allows that frontier to be breached and allows us to offer minimally invasive surgery to our patients. Again, we'll see shorter length of stay, a decreased conversion to open surgery versus a laparoscopic approach, meaning that if you start laparoscopically, are you going to stay that way or not? Is it going to be too difficult? Are you going to get into bleeding? Are you going to lose your plane? Whatever it may be that is the factor that causes you to go open, then you end up going open and you accrue the cost of the laparoscopic and the operating room time, and then you're in a position where you've got to do it open. And that decreases with the robot as opposed to lap. And then the other question, again, getting back to my point number 2, my assumption number 2 is that surgeons like what's best for surgeons. Is it going to be easier on me? Am I going to have less back pain, less neck pain, less, more durability because I'm not, dancing and standing in awkward angles for hours trying to hold up against, a 400-pound wall of fatty tissue in a patient who's obese. It gives us, the classic robotic advantages are that I can do a fine dissection. I can take a high-definition 3D camera and put it a few millimeters away from a blood vessel, and I can dissect almost every cell layer off of that vessel if I need to, whereas I can't do that in other techniques. So those are kind of the benefits. And the other advantage, which we don't really think about very often, but has become really profound in my practice with the robot, is that I have total control of the instruments. I know exactly where they are. I know how much tension is on there. I'm not relying on my partner or a resident or a PA or whomever we're operating with to hold, an instrument that is critically placed, that if they sneeze or move or pull a little bit differently than I do, causes a tear or whatnot. And so I have total control. Again, this is the cons. Cost, definitely something we have to think about. We know that robot surgery, as of now, takes longer than open surgery. It takes a while to set up. It takes a while to put the robot in. It increases that operating time. And there's no proven benefit over laparoscopy. We'll talk about that study. And then I messed up, but the ACOSOG trial is the one that talks about patients with stage 2 or 3 rectal cancer. The use of laparoscopic resection compared to the open resection failed to meet the criterion for non-inferiority for pathologic outcomes, meaning that perhaps we shouldn't be doing minimally invasive surgery at all in patients with low rectal cancer. Just a whole furor you can imagine in the colorectal world with that study, because most of the innovators are doing it laparoscopically and getting good results. And so that was kind of a ground shift on that one, and there's lots of studies that have argued that since. But the point is made that if you're going to do it, you've got to do it well. Otherwise, it isn't superior, and it certainly is inferior. So this is the ROLAR study, and this study is ongoing, and it was presented at the ASCRS, the Colorectal Surgery Society meeting in Boston this year. And basically, it's 40 surgeries, 29 hospitals, 40 surgeons, 10 countries. It's a prospective trial looking for superiority of robot versus lap. And they assume that the robot converts less. That's their main point. They assume a 25% conversion to open from a laparoscopic surgery. Again, basic premise is that converting to open means that you're either in trouble, the patient's not doing well, or you're doing a subpar surgery that you need to fix. And so that the outcomes and results show that there's no statistically significant clinical or oncologic benefit to the robot in this setting. The TME, the total mesorectal excision, the lymph node harvest, margins, planes, all of that is the same. Robot and laparoscopic, there's not a difference. So maybe we shouldn't be using the robot for those. And again, you'll see, I have that reversed on my slide. The lap conversion rate was 12%. The robot was 8%. In obese, they converted 28% of the time versus 20% of the time with the robot. And for low rectal, again, they converted to open 13% of the time versus with the robot 7.2% of the time. Importantly, neither group was close to the assumed 25% conversion rate. which probably has something to do with learning curve, meaning the surgeons were better prepared, they were better trained than they thought they were laparoscopically. And on the robot, they were able to match those, if not exceed them. So the trends, have they gotten a higher end? And I'm curious to see what happens as they, peruse through more data. But the trend you can see is that the robot does have a lower conversion rate, but statistically there wasn't a significance to that. We're going to skip this one too. Bottom line, it's a study out of Cleveland Clinic looking at the ACS NISQIP database, which again is the College of Surgeons huge database where we can go and mine data. They looked at 12,000 colectomies that had been done in 2013, found 387 per group after matching both robot, laparoscopic, and open colectomy patients. And they found that with the robot, they had longer OR times, but shorter length of stay, lower morbidity, less transfusions, less infections, and less ileus. And then even adjusting for any confounding variables, comorbidities, et cetera, the robot had a shorter length of stay in the hospital. I'm skipping that one too, and that one. So looking at colorectal, I think in summary, what we'll see is that the robot does give us less time in the hospital. It does give us the advantages of minimally invasive surgery. I think the trends are there to suggest that, certainly it's doable and it's equivalent. I don't know what the long-term outcomes are going to be. I think it's worth exploring. I think it's worth doing. If I'm doing a primarily open low rectal surgery, should I look at doing the robot? I think there's enough data and evidence to say yes, it's probably worth doing, but we don't know yet. Transitioning to my neck of the woods, I don't do much colorectal anymore, gratefully. I don't like the smell. I'm not going to admit that again ever in public, but nonetheless, my cup of tea is more in the foregut. And so when I look at the pros in the foregut, specifically with the Heller myotomy, which is, again, one of my favorite surgeries to do, the robot definitely shows a lower perforation rate versus the laparoscopic approach. And a lot of that, again, has to do with my vision and the tension that I'm putting. So if you can imagine that we're basically cutting a 10-centimeter line down through the esophagus, starting at its adventitial layer, down through the muscle layer, and trying to preserve the integrity of the mucosa on the innermost lining of the esophagus. The variability of the tension that I'm putting on that cut muscle edge makes a big difference as to whether or not that 2-millimeter mucosa tears or not. And so the gold standard nowadays to do this surgery is going to be a laparoscopic approach. We know that the laparoscopic perforation rate, meaning the tear in the mucosa rate, is about 6 to 10% nationally. And I've seen that in my practice. About 6 to 10% of those patients will get a perforation. Gratefully, it's almost always recognized at the time of surgery nationally, and the complications long-term of perforations aren't that great unless it's unrecognized, and then it certainly could, be fatal if that happens. But long and short, it does increase length of stay. It increases radiology studies. It keeps the patient's NPO for several days, that heals, et cetera. So there are significant ramifications in perforation rate. When you look at, and we'll talk about some studies here, but for Heller specifically, there is about a 0.5% risk of perforation with the robot. And again, it's because I have the tension, and it doesn't change. There's no variability. The robot allows minimally invasive foregut, surgery done with minimal assistance. So as a single surgeon operating, I don't have to recruit a partner or a senior resident to hold that cut edge of the myotomy, or to help me dissect around the esophagus or on top of the aorta, or to help preserve the vagus nerves. And I can do it by myself with the help of an assistant that's less qualified, whether that's a tech, whether that's a junior level resident that's learning the procedure for the first time. I have that control because the instruments are in my hands, and they can kind of help me as they need to, or not, frankly. So I can do that. It's easier with obese patient, and again, the same general benefits of robotics. The cons to foregut, again, cost. Again, the bazooka effect. Do I really need a robot to sew in Nissen funnification? In my practice, I don't. So I don't do robotic Nissens, and I don't do robotic hiatal hernia repairs, because the way my practice is set up, I've got a PA that works really well, with me. I have residents that will come occasionally. I'll work with my partner or whomever, and we have a nice streamlined pattern to do that together, and we can get patients in and out well with the minimally invasive surgery. So I haven't adopted robotic techniques for that. For hiatal hernia repairs, paraesophageal hernia repairs, et cetera. This again, I'm going to kind of skip through here, but this demonstrates that looking at that perforation rate between lap and robotic, again, 8% perforation rate in laparoscopic approach versus 0 with the robot. I'm going to skip through some of that in the interest of time. Conclusions again, the robotic approach allows us to significantly decrease our perforation rate versus laparoscopic. And the long-term outcomes trend to benefit for the robotic technique. The increased costs at the time of surgery, the longer OR costs, seem to be justified in light of improved safety with a lower perforation rate. My average length of stay in a robotic Heller myotomy is less than a day. So most of the time they'll come in, I keep them in field at night because I'm still too chicken to let them eat right away. And I give them some liquids in the morning. If they do well, they go home, usually by 10 a.m. Moving on to pancreatectomy. In my experience, so I started doing pancreatectomy open, trained in Philly. We did a lot of Whipples. As a chief resident, I did 40 Whipples, which the average surgeon in the United States has done 5. So yeah, I had great exposure and great experience to do these surgeries, whether it's for cancer or precancerous lesions. And so I came at it with a pretty good wealth of experience. And then I went to DC and did a minimally invasive surgery fellowship, and the wheels started turning and said, wow, this would be really neat to be able to do, the granddaddy of them all, the Whipple surgery with a minimally invasive technique. And so I wanted to do that. And in my experience, I did October 2014, did the first robot Whipple in our area. So I worked trained with a couple of docs, one in Chicago and one in North Carolina, and went out and observed and watched with them. And then I did a few cases and then went out to Pittsburgh and worked with them, where they do quite a few of these as well to get different techniques. And I've done 10 robot Whipples since that time, and my operative times went from 14 to 6 hours. My average blood loss in a robot Whipple is usually about 100, maybe 150 milliliters of blood total. The average in an open technique is somewhere between 700 and a liter of blood. My transfusion rate is really low. Most patients will go home within about 6 days. Certainly a Whipple is fraught with complications. So a pancreatic fistula or a leak from the pancreas, my rate is still mimicking that of open, which is about a 40 to 50% leak rate. And it's about the same character. Some of them have been really bad, some of them haven't. But in most cases, the advantages I've seen is that they get out of the hospital and they're almost normal within a couple of weeks. They can get the chemo faster if it's cancer surgery. They can then move on, as opposed to a big open Whipple, with the stem to stern incision and several drains. That usually takes about 6 months to get to where you want to be, and you never really make it back for that time period. So it's really been quite dramatic. I did a central pancreatectomy on a young guy, 21-year-old guy, just not long ago, for a tumor in the middle of his pancreas. So I pulled up a loop of jejunum and plugged his pancreas into that and took out the central portion. And he went home on post-op day 2. It was, I was sweating that one. I didn't get any sleep, but he did super well. And so you have these patients that prior to that would have gotten this really impressively effective surgery, but also affecting their life. It's both effective and affective. It really changes their life. And you give them the opportunity to have a minimally invasive approach, and they fly, and it's really phenomenal. So in my experience, I think minimally invasive surgery being an option is huge in pancreatectomy. Significantly less blood loss, all of these things. I can save the spleen more regularly, which makes a difference in patients. Where are we going? We've got 2 minutes to talk about where we're going a little bit here. I think the future is clearly bright. We'll continue to innovate, but what are the costs? What is the responsible course of action? Just because we can, should we? And I think that's kind of the question. When we look at costs, there are direct costs. This is where the robot, in particular, is really a weight. It's a very expensive machine to purchase. The company that makes them limits the use of the instruments, so you have to re-up on instruments every 10 times you use that. You can't use it anymore. There's a chip in there that locks it out, so you can't use it. So I'm sure that's a way that they can continue to make money off of us. And I think as we get more robot companies into the breach, which should happen in the next couple of years, Google and Ethicon and Medtronic all have robots coming out. that hopefully will decrease some of those costs. But it's a significant capital investment. OR time is consistently longer in each procedure than the others, and the overhead costs are there. But the downstream costs, length of stay, conversions, complications, readmissions, these are just a slide showing general, costs that are associated with each of those, which you can see add up really quickly. So if I can get somebody out of the hospital a couple of days early, if I can decrease transfusion risk, if I can prevent readmission because they don't have a big infection, if I'm saving $20,000 per case on that. So I think the downstream costs are important. I can do patients more outpatient with the minimally invasive approach, which generates significant benefit to the patient as well as to the hospital as Medicare is changing their reimbursement strategies to favor outpatient procedures. Kind of where are we going? I think it's important that we have constant objective introspection and evaluation. At Intermountain, which is where I am, we have a system-wide cohort comparison that we're setting up between lap robot and open for each procedure that we're doing robotically. We're doing our best to maintain good data analysis. We do it per procedure, per facility, per surgeon. We can really break and drive down the data to show me exactly how much it costs me to do this procedure, and then I compare that with outcomes that I know and bring it to the table and say, yeah, this is a benefit, or you know what, maybe we should not do this, and we've done that before. We have quarterly service-specific outcomes review meetings where we all get together as general surgeons or gynecologists or urologists to say, yeah, who's doing the best prostate from a cost standpoint, from an efficiency standpoint, how can we mimic that repair? And we do it in a collaborative way. It's not punitive at all. It's really a phenomenal meeting. And then we can also use the robot, I think, to make sure that we're still getting good training. We're still doing good surgery. The big fear, most of us, we get great training in residency, and then we go out and practice, and we may never change. We may do what we do for perpetuity because nobody's there to tell us to do it any differently. And so there's really no, other than just the drive assumption number one that says I want to do what's best for my patients, I could do the same surgery over and over again. And a lot of us do that. And so I think with robotics, we can interact with telerobotics, where somebody's sitting in an office somewhere else and sees exactly what I see and says, hey, why don't you try this? Or hey, what do you think about this approach? And really kind of we collaborate with one another. And I think that that's a huge thing about where we're going to go. And then I think, again, once we get more competitors on the market, those costs hopefully will decrease. Thank you. I've talked way too much. My mouth is really dry, but thank you very much. I'll take questions.
I have more comments. So, this is Harrison. Great information. Thank you.
Thanks.
As a physical therapist, I, of course, look at it from the point of view of we can help. We can reduce the recurrence rate. We can help reduce the readmission rate by helping people build their body somatic awareness, body mechanics, get some activity going, especially for those obese people, and help them with what looks like minimal scar tissue. But there's a lot that we could do to improve your outcomes.
Yeah, I thank you for your comment, and I totally agree. And in my experience, I've worked with groups of physical therapists as well as exercise programs and walking programs and enhanced recovery programs to do exactly that. So I think you make a great point. Thank you very much. I absolutely agree.
Thanks for a really informative talk. I'd be curious to know if any studies have been done or are underway that look at the final costs attributable to a given procedure comparing standard and robotic methods, so that we aren't just looking at qualitative measures. Well, it costs more for OR time because it's longer than we're using a robot versus we save time and length of stay.
Yeah, great question, and absolutely is the answer. I think it's very difficult because of the variability in how patients are tracked once they leave the hospital. I think it's difficult in how, frankly, it's almost, we're still struggling trying to figure out what those direct costs are with robotics, how to appropriately charge a patient or a system for that huge capital investment. But I think your point is spot on, and certainly within Intermountain, I can speak of that because I know what we're doing. But yes is the answer to that question, is we're gathering all of that data in cohort analysis, trying to figure out who's come back, who hasn't, when they came back, how much did that cost? What was the ramification of that? Was it just a quick ER visit with a CT scan, which still is expensive, but, or was it a return to surgery, or was it a readmission, or whatever it was? And the answer to that question is, yeah, we're diving deep into that data. I don't know what's being done nationally on that, but our hope is to kind of drive that push a little bit, and gratefully we have a system built up that we can do that. Thanks, guys.